Good morning, everyone, and thank you to the IPC for giving me this honor to present on the special population. So I have no conflict of interest. I will be demonstrating on how psoriasis presents in skin of color particularly. Next. This is Nairobi. And the hospital that I work in, Kenyatta National Hospital. As I've said, no conflict of interest. So I'll be presenting on a 46-year-old male who presented to our hospital complaining of scaly plaques since 2009. He says that they first began on the nape of his neck and gradually spread to his elbows, trunk, and lower limbs. He has associated pruritus, but no skin pain. In the past year, he has developed nail changes but has no joint pain. He's married with 3 children, worked at a gas station as an attendant, but he's currently incarcerated and has been since April of this year. He smokes 3 cigarettes a day and has done so for the past 30 years. He does not take alcohol, and he reports no family history of psoriasis or similar skin disease. So he first presented to our hospital in May of this year with the scaly plaques, as I mentioned. We needed to do a skin biopsy, as that is what we do to confirm the diagnosis so that we can optimize treatment. All lab investigations were normal, including the metabolic screen, ECG, echo, screen for hepatitis, HIV, TB were also negative. We initiated him on methotrexate 25 milligrams weekly with folic acid, and he has also been applying betamethasone ointment topically as and when he gets it. As I said, he's in prison, so access to certain medications are limited for him. He's also newly diagnosed hypertensive as of 2 months ago and has been on amlodipine 10 milligrams once daily. His BPs so far are well controlled. So this is how he presented when I saw him. He had these thick plaques in the occipital region of his, of his scalp. So very thick plaques, some gray scales, and even some papules. This is the lesion that actually bothers him the most. This is his left breast. He has this thick plaque, hyperpigmented, with very gray, thick scales. And this is his axilla. So he has this hyperpigmentation. There are areas of erythema, although with our skin type, it's often hard to tell. When there is erythema, it will often appear as hyperpigmented or purplish, but for his case in the axilla, we had the erythema. And this was his elbow with the scaling, erythema, and hyperpigmentation. His legs also bother him significantly. He's been on treatment for about 4 months now, but he feels we are not making much progress. Very dark brown with the scaling and very itchy. And this was a solitary plaque that I found on his back with the scaling. We can see some, what we describe as erythema in the darker skin type and the thick gray scales. His nails, he has onycholysis. He does have some ridges and pits, which I hope can be seen there and there, as well as the onycholysis that he's experiencing, but no joint pain so far. So he's been on the methotrexate, the erratic doses of betamethasone. He gets it whenever we have it available in the hospital or in the prison medical clinic. And we decided about this is a week ago that maybe we should optimize with some narrowband phototherapy, which we have in our hospital, as we consider if he is a candidate for biologic therapy. This is because the surface area that is involved is quite extensive, about 10%. What I took photos of is what he allowed me to. He explains his pruritus as very disruptive. He is unable to sleep well, and he feels extremely embarrassed by his skin. It's difficult to assess DLQI in a patient who is in prison, but he said prior to his incarceration, he felt very embarrassed it would interfere with the social activities and the hobbies that he would engage himself in. So the challenges we are having, however, is stress. Could that be the reason why he's not responding as we would like? He's in prison, he's due to go to court, but he's unsure as to how the case will go. He still smokes cigarettes. I'm not sure where he gets them, given that he's in prison, but he's unwilling to stop. And he has the difficulty in accessing the topical agents that we would use normally. So we've brought in psychological counseling for the patient as we see the next steps towards his management. Thank you. That is the end of my presentation.